So as you can tell from some of the talks you've already heard and from the talks you'll be hearing, there's a lot to know and potentially a lot to do to help the patients. And although it may seem increasingly overwhelming to remember all of this, it's really increasingly crucial to have assistance to make all of this something that we can work with and handle the information. And so that's really the overall theme of this talk. And I'll be talking about artificial intelligence and augmented intelligence, and I'll explain what those are. This is an area that's interested me for a long time. Back 35 years ago, I was teaching about this at Harvard Medical School. And when the first neural networks programs book came out, I was the one who wrote the review in Science. And this is an area I followed for a long time and participated in, and I'll give you an overall perspective. Now, one of the things that's happened is that the terminology has shifted a lot. Names that were used in one way are now used in a different way. So let me explain what AI means now. It means two different things. One of them is artificial intelligence, and that's the one you'll hear most. But the other is augmented intelligence, which is a term you'll hear a lot in medicine and is to some extent the style of medicine in terms of resources we use like OMIM and ClinVar and so forth. And so let me give you examples of what these mean. Artificial intelligence now refers to using neural network programs, and some of you may use face-to-gene for looking at photographs of patients and getting suggestions on diagnosis. There's a lot of good work being done on radiology image analysis to say, look at this X-ray and does this look like a lung tumor and so forth. And there's a lot of work being done on natural language processing, specifically in the electronic health record. Now, programs like this work by a process called machine learning, which is a whole complicated thing I'm not going to go into. That was what the Science article that I wrote 34 years ago was about. And it involves looking at huge data sets and learning how to predict things. And there's some problems with this, specifically for rare diseases, the subject of this conference. The data is often not available in a way that would rise above the noise in any kind of machine learning. And it's also difficult to revise and remove outdated information. You know that you follow resources like OMIM and gene reviews, they keep saying, well, this really isn't associated the way we thought it was. And it's difficult to deal with the machine unlearning that type of information. Now, in contrast, augmented intelligence is more of a pattern matching approach. And we use that in the simulconsult software that you'll be seeing. And there's a similar approach in the Phenomizer software that has a similar philosophy, but is much more focused on research and comparing to other species and so forth. There's also augmented intelligence in rule-based systems like alerts in an electronic health record that will say, this dose of the drug sounds too high and you should be careful about that. The process by which augmented intelligence works is authors assembling information as in preparing a review article. And for pattern matching, it's really easy to revise the data because you just go in and you change what changed. For rule-based systems, that's historically been a big problem, but now rule-based systems are being used for more simple things like alerts in an electronic health record, and those are fairly straightforward to revise. Now, the goal of artificial intelligence is really to replace the clinician. It's to replace looking at a face and saying what disease that looks like. And you provide all the input at once, and you get an answer, but you get no explanation. Augmented intelligence can operate in ways that support the clinician. And specifically, medical diagnosis is really iterative. You put in some things and you think about the possible diagnoses and you put in other findings, because there's thousands of findings you're going to put in and you're not going to examine or test for all of those. And one of the crucial things is to prompt for which findings are likely to be useful, which I'll show you. The other part about augmented intelligence is that it's explainable, and I'll show you what that looks like as well. So the evaluation of artificial intelligence is usually comparing the doctor to a computer. The evaluation of augmented intelligence is comparing the doctor without the computer to the doctor with the computer. So what I'm going to do now is shift to actually showing you software. And should I move this to the center, or is this okay how it is?
Yeah, it's okay. Yeah.
Okay. So, well, first of all, let me acknowledge my collaborators. The top 25 authors and editors are shown here. And a lot of these people are top people at top centers or real experts in their countries. And it's been a wonderful group to work with. So I'm going to show you a relatively simple patient to give you a feel of how the software works and show you some of these themes like the iterative diagnosis and explainable diagnosis. And then I'm going to show you a microarray analysis later of a much more complicated patient. But let's start out with the simple one. This was a patient I actually saw during my residency, and it was an 8-month-old boy. And I'm going to put in the first finding. He had kyphosis and a big head. So I'm putting in kyphosis, and I'm putting in the onset because often onset is really important. Sometimes you'd say it happened by a particular age or was first noticed at a particular age, or you can say that it's absent. And these are all crucial types of information, as all of you appreciate. So the kyphosis we knew had origin around 6 months of age, and we could put in the macrocephaly, but let me show you how some of the iterative approach works. So here are a bunch of diagnoses and that come up because of the kyphosis. And there's the iterative useful findings approach comes in by taking a look at all sorts of findings in the database and asking how useful would they be in changing the differential diagnosis. And what you see here is the macrocephaly, which I'm going to put in. But let me start out with a short stature. This patient was not short. In achondroplasia, they would be short by now. In Hurler syndrome, they would not be short yet, but they would be short later. So I'm going to say that this patient is not short. So that argues against achondroplasia, but it doesn't argue against Hurler syndrome. So I'm going to put that in as a pertinent negative. And achondroplasia goes way down and other things creep up a little bit, but nothing has a very high likelihood yet, as indicated by the blue shading, which you can probably just barely make out. So I'm going to put in the macrocephaly. Onset was known to be around 6 months of age. And that pushes Hurler syndrome up to being more likely than any of the other diagnoses. And then it suggests looking for corneal clouding. Now, I'm a neurologist. I'd never seen corneal clouding before. I got called because there was a big head, but I could have clicked on here and seen links of what corneal clouding looks like. But somehow, I didn't have this software then. This is what convinced me that we needed it. There was corneal clouding, which I noticed because I was trying to look at the fundi, and it was of unknown onset because nobody had ever looked before. And when I put that in, it pushes very strongly towards a diagnosis of Hurler syndrome. And that's where we were in terms of clinical findings, and we decided to add some tests. And the tests are also organized by usefulness. And There's various things like the glycosaminoglycans that we eventually did, but we couldn't do them right at that moment. Kid had a big head and needed to be shunted. We did do limb bone imaging, looking for dysostotic thickening of long bones, and that was present also with onset unknown. It doesn't change Hurler syndrome, it changes a lot of the other possibilities, but it convinced us that we knew what we were doing, and that the patient would get proper attention to the upper spine during the shunting operation, because that's of importance in Hurler syndrome. So I've shown you the iterative part. Let me show you the explainable part. We can assess the diagnosis by taking Hurler syndrome and looking at all the pertinent positives that we put in and the pertinent negatives. And you see that these pertinent positives and negatives are, they have some shading, which is a metric of pertinence. In other words, how much the differential diagnosis would change if this finding were not there. And so the pertinent positives are colored in black by the frequency at the indicated presence. So here we say recent, and in recent time, most of them would have macrocephaly. Some of them would have had macrocephaly before, some later, and so forth. But there's a lot of black here, which is a good match. And similarly for the pertinent negatives, although they would all have short stature, very few would have short stature now. So this is a really good match, and you could look at other diseases to see how good a match those would be. And you can see that the differential diagnosis depends on all of these findings and their pertinence. And keep in mind the pertinence, because it's going to be important when we look at the analysis of the microarray. We could do various reports from this, and specifically, let me point out that you can save summaries and you can save a computable patient summary. And the advantage of this is that you can reload the patient, as I'm going to do when I start microarray patient. So let me move to that patient. I chose a patient who is from the Gulf, and the parents are first cousins. And so it really illustrates some of the issues that you have to deal with very often. And I know Dr. El-Khattab, and I'm sure many others of you, order microarrays in order to get some sense of what genes might be causing illness when the parents, when there's consanguinity among the parents. So let me load that that patient, and so here you'll see the various findings that are present, and there's a whole bunch of diseases that are possible. You notice one of the findings is achalasia, and one of the diseases has achalasia in the name. We'll keep track of that. You'll also notice that there's other diseases that are described in the region, and that all of these, there's 8,000 diseases that are being considered as one goes through this diagnosis. So when you do a microarray, you get a list of various regions that are abnormal, and you can translate that into lists of the genes. And there's this list here is 5,559 genes, but as you can see, many of them are repeats. So what I'm going to do is copy that, and we're going to use that in the software. And so we're going to look for regions of homozygosity. I'm going to paste in the genes and load the genes, and it's going to go through removing the duplicates. And there's 2,399 unique genes. And when I click to the diagnosis screen here, there's a new tab called Genotype. And in the genotype are 13 screens, so that's probably 400 or so different genes that have clinical phenotypes in the among the genes that are in the regions of homozygosity for this patient. So not surprisingly, this disease with achalasia comes up highest or comes up very high, and the Gmpa gene was called and checked on the basis of this. But what's interesting is when this was first run, these other two genes and these other two diseases didn't come up because there had been no described clinical phenotype for those genes, and these diseases had not been described. Let's first look at the argument for the Gmpa gene, and we'll assess its disease, and we'll see that there's a lot of black, which is a good match, but it explains the achalasia, doesn't explain 5 of the other findings, which could be just because the disease hadn't been described in great enough detail, or could have been that there's more than one disease that one should consider. But nothing had come up before, but this illustrates the importance of reanalysis. It just takes a few minutes to take the previously existing set of genes and just run them up against what we know now, as opposed to what we knew 6 months ago. And so one of the things that came up was this EXOSC1 gene that corresponds to a newly described form of pontocerebellar hypoplasia. And when you assess that disease, you see that that it also explains a bunch of findings. It doesn't explain some of the findings that the achalasia disease accounted for, but it explains the other ones. So what's quite possible in this case, and the Sanger sequencing will be done of these other genes, is to say, well, it's possible that both of these are also involved. You could have 2 genes, maybe even 3 genes involved in the phenotype. And it's important for, at least for family planning reasons and possibly for therapeutic reasons, to figure out what the diagnosis is. So what I've shown here is an approach to microarrays that allows you to deal with this huge complexity of information, but also allows you to deal with the huge increase in information as knowledge progresses, that you don't have to go looking reading all of those papers before you have the relevant patient. You can then be directed towards the diseases that you need to consider. I'm going, one of the points that I want to make is that not only, as I showed in this previous slide, are you likely to be using both artificial intelligence and augmented intelligence, but one of the themes I think you're likely to see is that various software tools are going to use both of these approaches. And let me give you an example from a paper that we just published incorporating natural language processing, one of the artificial intelligence approaches into our augmented intelligence approach. Now, as you saw, we have the ability to understand the area and, based on the patient's findings, to suggest useful findings. And the natural language processing has the ability to look and see what was mentioned in electronic health record and tell you when it was mentioned, so you can decide if it's present or absent and the onset. So each of these is an important capability, but the combination of them makes an even more powerful capability, because you have the ability to look in the electronic health information, in the electronic health record, for information that is both there and useful for your patient. And that's terrific in terms of being able to focus you on what's important and what you already know, in addition to other things you may want to check. So given the huge amount of information that we have to deal with, capabilities like this are the only way we can really cope with all this information. So you can, our augmented intelligence approach at simulconsult.com is something you can get a free trial and try all the capabilities that I showed you, except for this slide. This part isn't available yet. It's in fact being incorporated inside the firewall of medical centers, but you can try the rest and get a sense of the types of approaches that are becoming available and in some ways becoming essential. So Dr. El-Khattab, we could do questions now, or we could, I could also show how the same technology can be used for interpreting exomes. What do you think we should do?
Yes, I mean, if you'd like to present the exome, yeah, I think we still have like 2 minutes if you like to. Yeah.
The 2-minute exome. So here's a patient. This was a patient in the Harvard's genome interpretation contest, where we were one of the ones honored for our approach to the patient. It was a patient with centronuclear myopathy, as judged by having centronuclei and myopathy, but also had hearing impairment. And so it was kind of confusing. They checked for the centronuclear myopathy genes. They didn't find anything. So if you load up the exome, this will take about 7 seconds to go to the server and half a second to be analyzed. And it's analyzing 32,000 rows in the variant table. And here you also get a genotype display. And here also it's not ordered by the severity of the variants, it's ordered by the pertinence. In other words, the ability of the genetic abnormality to affect the differential diagnosis. So the main thing that came up was a type of myopathy called Salich Myopathy. But if you look at it, it explains lots of things, but it doesn't explain the hearing impairment. And so you could look at the hearing impairment, you could look at the other diseases in the differential diagnosis, and of course, some of the mitochondrial diseases come up because of myopathy, and deafness is often present in mitochondrial diseases. But notice here, there's also a autosomal recessive form of deafness. And if you happen to notice on the analysis, that was number 2 in pertinence. So what we've been able to do is the pertinence metric here has been able to pull out the 2 genes that are necessary to explain this phenotype. And you could, I won't go into this in detail, but you can look at the variants, and all of you know that Titin is one of the biggest genes, and these are the 2 variants, one in the proband from the father, one from the mother. There's 2 other variants that showed up, but those are colored in blue because those are too frequent to be pathogenic, because if so, the frequency of the diseases would be higher than it is. So we could go through and report and everything, but don't really have time for that. And but this is a capability that is also available. Okay.
Thank you very, very much for this fascinating talk. And Dr. Segal can take some questions, if we have questions from the audience. Any questions? Okay. So Dr. Segal, I have one quick question. Like maybe similar to the last case that you have shared. I mean, here, because of the high rate of consanguinity, it's not uncommon to have like 2 autosomal recessive diseases, or in rare occasions, even like you may have like 3 diseases. So how good is using such software in finding out like multiple conditions in the same individual?
As far as I know, we are the only ones who have an approach that helps you deal with that. The pertinence metric that we use, and let me put back up the pertinence metric, and we've published on that, is the only approach that anybody's found for dealing with the 2 diagnosis problem. Now, of course, it's restricted only to a subset of patients with 2 diagnoses, ones where you've either done a microarray or an exome, and both of the conditions are genetic. But from the experience that you have in regions of high consanguinity, this is actually a fairly common occurrence. And so having solved this part of the problem actually provides you with an ability that is really important to your clinical practice.
Thank you very much. Any other questions? Okay. So thank you very much, Dr. Segal. It was really a pleasure to see you virtually, and hopefully we'll meet in real soon. Thank you very much.
Look forward to it.